So everyone, welcome. This is Ray O'Leary, who's with Missouri Breaks, and she's going to present for us today. And if you are joining, please mute yourselves. Thanks. Take it away.
Great, thanks, Julie. So as Julie said, I'm Ray O'Leary. I am joining from Eagle Butte, South Dakota in my car. And I'm going to be presenting today on the Promoting First Relationships randomized controlled trial that we did here on the Cheyenne River Reservation, as well as some other related MCH, maternal child health work that we're doing currently. I'm an enrolled member of the Turtle Mountain Band of Chippewa, which is located in North Dakota, but Cheyenne River has been home for about the last 15 years for me. So you can see here that this is some of our Missouri Breaks team. We have 4 office locations with Missouri Breaks. The main office is in Eagle Butte, where I'm located on the Cheyenne River Reservation. And we have 2 offices on the Oglala Sioux Tribe, also in South Dakota. Another office in Spirit Lake, which is in Fort Totten, North Dakota, and then an urban site in Rapid City, South Dakota. So each facility does kind of their own research projects. Some of them cross over to multiple sites. The most notable study of Missouri Breaks is the Strong Heart Study, which is the largest epidemiological study of American Indian heart health. And we are just getting ready to begin phase 7 of the Strong Heart Study. So that's kind of the buzz around the office right now. But a lot of my work has been focused on respiratory research, but also more recently, socio behavioral health interventions and MCH related topics, which is really where my passion lies. So if you're not familiar, here is, of course, the state of South Dakota within the United States and the Cheyenne River Reservation, which is centrally located and has a pretty large land area. We are the 4th largest reservation in the United States at about 4,200 square miles, which is equivalent to approximately the size of the state of Connecticut. So a pretty large land area. And we are home to about 10,000 people, predominantly Native American, and a high rate of poverty in our communities. And you can see here a photo of the river. And so the study that I'm going to be spending most of the time for the presentation on is a primary prevention trial to strengthen child attachment in a Native community. And the intervention that we trialed was the Promoting First Relationships, or you also hear me call it PFR. It's a strength-based home visiting parenting program. And our aim was to really just see if it works and is feasible in Native communities. We were one of a couple sites that tried this intervention out and had great success, which I'll get into in the next slides. We had 3 publications that were just recently published here in the last few months that I'll be highlighting. And you can see our team here with the University of Washington School of Nursing and Partnership for Native Health with doctors Catherine Booth-LaForce, Deidre Buchwald, and Monica Oxford that led this study. And our funding came from IREACH. So if you take a look at the kind of the big picture of this study, we enrolled about 162 primary caregivers, predominantly Native and female, and their Native toddlers that were between the ages of 10 and 31 months, and an even split of female and male infants and toddlers. And you can see that after recruitment and consenting of those participants, they had a research visit, and they were given $50 for compensation. From there, they were randomized in either the PFR intervention group or a resource and referral control group. And I'll get into the details on the difference in the next slide here. From there, they did a research visit time 2 that happened 3 months from baseline, and then another follow-up 6 months from baseline, and $50 for each of those visits as well. So this is just kind of an outline of the actual PFR intervention. You can see on the right, there's 10 weeks where we did a 1 session per week visit on the different topic areas that are listed there. Each visit consisted of the first maybe 10 minutes, just check in and joining with the participant and their child. And that's kind of where we just break the ice and revisit maybe anything from the past week that they wanted to talk about, or anything that they noticed from the previous visit. And then every other week, we would either do a video recording or a video reviewing, and we would give the participant instructions. Sometimes it was just playing with their child. Other times we might ask them to teach them a new simple task, like building a stack of blocks. One time we did do a separation video, and each following week, then we would watch the video back with the participant, use reflective questions and positive instructive feedback. And really, again, this is strength-based. So we just put a lot of emphasis on all the positive things that we see in the videos, and ask reflective questions on anything that maybe needs more exploration or discussion, or any difficult moments maybe that were captured in the video. Each visit has handouts to accompany and like reinforce the material that we went through, and then discussion, of course, that was specific to the child. And then we would close with sharing some thoughts for the week and encourage them to really think about that topic and try to notice things that were relevant to the topic until their next visit the following week. And then the control group, I don't have details on this, but the resource and referral group, or arm of this study, basically they had 3 phone calls with somebody who helped assess any resources that they may need in their home, and give them contact information for programs that might assist with those needs. So the first of our papers that I'll highlight here is an implementation fidelity paper. And really the highlight of this is kind of the partnership that was established with Missouri Breaks to conduct this study. I will say that, being with Missouri Breaks, I'm proud to share that we have a great experience with our community members. Most of our staff are from the community, most are Native. We have, almost 30 years of experience doing research with the community, and I feel like we are a trusted community organization, and that really set us up for success with this study. It's also worth noting that the Fort Peck tribe in Montana was the original site for this trial, and they didn't have quite the infrastructure and capacity and experience, I guess, with conducting research studies, and had a little bit more of a hard time with staffing and recruitment. But I think it just goes to show that, the value of, strong partnerships when conducting studies in tribal communities. In this paper, you can also read about the process that we use to train and certify Native community members, including myself, to deliver the PFR intervention. And there's a pretty rigorous process to assess fidelity and quality of the delivery of the intervention. And we always exceeded the criteria for that. We had high participant satisfaction and high fidelity, despite, of course, the inherent challenges that we deal with here. I want to highlight some of the cultural adaptations that are in this paper. It's not a big focus in the paper, but I think it's very relevant to anybody interested in working with tribal communities in the context of research. And I also want to point out that any cultural adaptations are going to be different from tribe to tribe, community to community. So it's super important to, follow that community-based participatory research approach and find out what's going to work for that particular community. But for our case, we found that, it's kind of a cultural protocol to provide a gift as a thank you. So the child received a gift a couple times in the study. We also had to revise some of the discussion questions to be more trauma informed and sensitive. And I feel like that was a very good move, that we turned something that could have been kind of triggering into a positive experience or a memory for the participants in some discussions. We also had extra time for check-in, and we found that this was really important because so many of our families just had other life things going on, that it helped to check in on just the everyday things. How's childcare going? Did you get, your you're renewed for, certain services that they were trying to qualify for, or housing needs. So that was a time where we could just kind of check in on their overall well-being and do what we can to support them in any needs that they had. And then, of course, the option to meet in the office. Again, this was a home visiting service, but we found that a lot of our families were just logistically, it made more sense for them to come to the office. Some of them are, in overcrowded homes, and it just wasn't a good atmosphere to do the visits at. So having that option was very valuable for a lot of our families. And then there was other situations with like transportation that made it difficult for families to come in once a week for the visits. So in those instances, we gave the option to combine visits. Some of our community members travel over an hour to get to our Eagle Butte office. So it's quite a burden and expense, if they're missing work or need to arrange for childcare. So it made sense for some families to do multiple visits in one session, which we accommodated as needed. And then for the RCT results of this study, we saw significant differences between caregivers in the PFR group versus the resource and referral group. In the area of the PFR group had higher scores on knowledge about children's social and emotional needs at both research visits 2 and 3. And again, that was at 3 months post-baseline and 6 months post-baseline. We also saw less severe depressive symptoms at both of those visits. And the quality of caregiver-child interaction improved at the 6-month or the third research visit. But it's important to note that this was moderated by severity of depressive symptoms, which is kind of intuitive that participants that had low levels of initial symptoms had the greatest impact in their caregiver-child interactions. It is worth noting that, one of our limitations is that we had only 51% of the participants in the PFR group actually complete all 10 visits. And we think that this had a big piece of that was our lack of compensation that was built in for the intervention visits. So if you remember from our study flow, they receive $50 at the baseline, $50 3 months post-intervention, and then 6 months. But there was no compensation for childcare, travel expenses, missing work to attend those 10 weekly sessions. And that was a big barrier for a lot of our families and their ability to complete the intervention. And I will say that's probably something that if you are working with a tribal community, it's important to discuss what those local norms are with communities and kind of get a good estimate of what it takes to get good participation. So following the trial completion, because we had, a high rate of non-completers and also a lot of great success with those that did complete, we just wanted to understand a little bit more about the experiences of the participants. So we did some post-intervention focus groups. We had a total of 3 of them. 2 of them were for people that completed the 10 weeks of PFR intervention, and we had a total of 11 participants in that those 2 focus groups. And then the third focus group was for the non-completers, and we had a total of 6 participants in that. This is a busy slide, a lot of information, but these are the themes that we identified following analysis of the focus groups. And you can see, I'll just highlight a couple of them. The first theme is appreciation for PFR providers in the program. There was a lot of people that appreciated the staff and the structure, and others that just liked the handouts and the materials that were given. This one said, I liked all the handouts. I really liked it because it was a huge refresher course, and I kept all the paperwork and gave it to my daughter and told her to read them. So that was great to hear that there was some sharing of the materials between family members. Another theme was personal growth as a caregiver. You can see that some of them felt like they had more insight into the child's behavior. One participant said, I give them more choices. Like if I say you're going to do this, I wouldn't like that. So kind of giving more choices. Improved caregiver-child relationship. we saw a lot of participants that reported a deeper connection. This one says, my favorite resource was staying connected during difficult moments. I get frustrated. It doesn't do anything if you're arguing with your toddler. So this really helped with staying calm. Just pause. It's best to just keep them calm, ask what's going on, and try to find out why they're acting out. And then some of the participant challenges that we learned related to participants' comfort level being on camera or video. We had multiple people that expressed discomfort with that made it difficult to attend or complete the service. And others that were just looking for more instructions when we turned the camera on, what they were supposed to do. And then a couple themes or sub-themes surrounding their reasons for not completing. This one says that at the time I was living with the child's dad's family, and it was really crowded there. So like the home visits weren't really working for that family. And then you will get down to some of the suggestions. We don't only want to know, what was challenging, but what we could do to improve this for future iterations or implementations of PFR in Native communities. And one that I thought was really interesting was including others. We had a lot of participants say that basically they wanted to incorporate other adults in the household into the PFR intervention. This quote says, it's not just the moms or the dads that are involved with the child's life, it's everybody. And I think that's very consistent with our Lakota Lifeways, that it's really, kind of that it takes a village to raise a child, right? But I feel like that's even more present in Lakota communities. That's a way of life to look out for each other and help when needed. So that's one very interesting suggestion that we hope to explore in the future. And we had a lot of feedback about people really enjoying the service and wanting to see it continued. Stuff like this is really, really needed. A long time ago, there was a program called Phaser, then it went to Healthy Start. Then there's nothing here right now. So this is a good resource. And this kind of makes a point of sustainability. So since this study ended, we've not been able to implement PFR in our community as we had hoped. But I think that, we're continuing to try. We're constantly reviewing grant opportunities and trying to find ways to implement PFR in our community, partnering with state, looking at tribal McVie grants. So far, we're nothing's come to fruition yet, but I just want to make a point that it's so important to think about sustainability from day one of grant writing and prep. For these communities. If we find something that works, let's make sure we have a plan in place to implement it long term. And then to kind of switch gears, we do have another program that's going on right now that I thought was very relevant and similar to PFR, just kind of with a different age group. And that's called the Communities That Care. And this is based on a framework that we're supported with the University of Washington as well. And most of you are probably familiar with Communities That Care, but we've been doing this since May of 2020 on the Cheyenne River community. And we've had great success. We're currently just about finished with phase 4. And kind of to back up, the big picture for Communities That Care is, establishing a coalition of stakeholders who are vested in youth outcomes. That's both protective and risk focused. So to assess what our greatest needs are in our community, we did a survey with 6th through 12th graders and identified the greatest risk factors and the lack of protective factors in certain areas, and then chose 4 of them to be our priorities as we move forward. So following the survey, we then did an assessment of the entire community to find out what's currently being offered to address those 4 priority areas and what gaps are needing filled in those areas. So right now we're in this creating a plan phase where we've analyzed using the Blueprints website, multiple different evidence-based programs to implement that address our priority areas. And we've chosen 2. And we're kind of in the process right now of working through all the logistics of who can we partner with and how can we fund the implementation of these programs. So when we get to phase 5, that's the implementation phase that we're currently seeking funds for. And on this slide here, you can see the 2 evidence-based programs that we are seeking to implement in the community to address our 4 priority areas of family management, alcohol, tobacco, and marijuana prevention, commitment to school, and depressive symptoms. The 2 programs are Strengthening Families and Positive Actions. Currently, Positive Actions is being implemented by one of the school systems that we partner with, but only in a select group of grades. So we are looking to expand that to more grades and do kind of like the community and family implementation of that rather than just the school-based implementation. And then to address family management, and again, the substance use, we'll be seeking to implement Strengthening Families. And interestingly enough, Strengthening Families, like I said, is an evidence-based program, but similar to PFR, there's now a randomized controlled trial happening with our partner office in on the Oglala Sioux tribe for Missouri Breaks, and that's basically an adaptation for Lakota communities using the Strengthening Families curriculum. So we're hoping that as soon as that study is finished, if the adaptations are effective, that we can implement the Lakota version of Strengthening Families. And then this social development strategy is something that all of our CTC work is based on. The general idea is that if kids are given opportunities, skills, and recognition in life, whoever they do those things with, or whoever provides those opportunities, skills, and recognition for them, they will bond to. And if that person also gives them clear standards, that will result in a lifetime of healthy behaviors. So this is kind of the general idea of the CTC framework that we're following. So that's just kind of 2 pieces of our work at Missouri Breaks. One being the PFR randomized controlled trial, and this being kind of a more public health upstream approach using research that's already been done elsewhere. So with that, I'll go ahead and pause and take time for any questions that anyone has.
Ray, I'm just going to jump in. Great presentation. Thank you so much. That was excellent and so informative. Many of us at IREACH have had the opportunity to work with Missouri Breaks, and it's incredibly rewarding. I have a question for you. In some of the research and behind the scenes, I know that Missouri Breaks keeps a database of interested participants because you've done the incredible legwork of building community and respect from people in the area. So then they reach out to Missouri Breaks or agree to be contacted. Certainly with PFR, it was phenomenal to partner with you all and start a research study with already interest, potential interest. Could you speak a little bit about your recruitment? Both of these studies were incredibly powerful and successful. Certainly my role with the PFR and doing outreach, it was incredibly rewarding to work with you all and how you did your outreach, and so much respect to community.
Yeah, certainly. So I think the biggest piece of our success in recruitment is locals. Like, we're all from here, we all have relatives and know each other. So that's a huge benefit to this. But for PFR, we also established an MOU with a tribal WIC program that basically has all the kids in the age range that we're looking for. And we were able to get a list of names and kind of have a baseline to work from for our recruitment. And then of course, there's lots of word of mouth of, once one family finds out about it, they're sharing it with their relatives and their friends, and it kind of spreads from there. But there's a certain amount of effort that goes into just attending community events and having that constant exposure in the community, doing good work in the community, and the people kind of come to you when they know good things are happening. So good question.
Thank you.
Hi, Ray. I thought I'd jump in and ask a question as well. So my name is Ben Piper, and I'm a research manager for a Alzheimer's and dementia study recruiting in urban areas. And we're in the process of recruiting 1,200 folks, natives in urban areas across the US, 5 different communities. And I was interested in when you were talking about incentive amounts, and that maybe the $50 was not adequate. I was wondering if you had suggestions for maybe what you thought might be a more appropriate amount.
Yeah, that's a great question. So I think that the $50 was appropriate for the research visits. Those, if I remember right, took a little bit over an hour and involved video recording, and it was not just the caregiver, but the child as well. So I think that was appropriate for the research visits, but I think what was lacking is any kind of, and I don't like calling them incentives per se, but rather compensation. Like, we're not incentivizing them to come, but we're compensating them for all of the childcare and their transportation costs and missing work and all the things that come with taking an hour out of their day to be involved in this research. So I think that even a gift would have been more potentially appropriate for those visits, if we could give them a gift of diapers or whatever is appropriate maybe for that child's age. That would have been something to keep them feeling like they're coming back in and their time is appreciated. If monetary compensation is not an option, that would be a backup. But of course, I think monetary is always best, because then they can use it how they need it. Maybe they don't need diapers, but they need gas money to get home. So I think that for those visits, maybe even $25 would have been appropriate for the length of time that they spent with us, to keep the retention of those participants higher.
Do you? So I want to follow up on that. Do you feel like gifts sometimes have more, say, value than money, or is more appreciated than funds or gift cards if it's an appropriate gift?
I think it depends from person to person. I mean, I think there's some people that just would appreciate the thought that goes into a gift, but I think for most people, they would rather have the money to put towards whatever their expenses they incurred were to participate in the study.
Okay. Great. Okay, thank you.
Mm-hmm.
And Ray, I'm not sure if you're able to see the chat. There's a question in there from Erin.
I can read it out loud too.
Oh, thanks, Erin.
Yeah. So I just wanted to say overall, like, great presentation, and I love hearing how holistic all of these projects are. My background and interests are in depression and mental health. So I know you mentioned that there was effect modification by severity of depression in PFR. And so I was wondering, I guess, if parents, attributed that depression to the stress around parenting, or if it was kind of more broad, and if there were other resources that were available for parents to kind of actually maybe target depression that might be happening simultaneously, but not directly related to the parenting.
Yeah, that's a great question. And I think that, I don't know if we had anyone, express that my depression is interfering with my ability to, be a good parent, or the stress of parenting is contributing to my depression. I don't know that we had any direct findings like that, but I definitely think that we can make some assumptions based on what we learned in this slide here, which is that their depression reduced. At the same time, their parenting skills and ability to respond to their child and be attached to their child increased. So, I mean, I think that there's we can apply that potentially that, the ability to cope with parenting and the stressors that come with that, and it being more attached to the child, thereby reduce the stress of parenting, which also then may reduce depression. Of course, there's a lot of linkages there and assumptions, but I definitely think you're onto something with that. And I think that's something that needs to be explored more in follow-up studies. And as far as, sorry, I'm just looking back to your question here. As far as the resources, definitely anytime that things like that were identified, we did what we could to connect them to the resources that are available in the community, but probably not unique to tribal communities. We have a very big shortage of mental health services and long wait lists to get services. So that's not always like a immediate fix, but certainly, we did what we can to connect them to the resources that are available.
So thanks, everyone.
Yeah, it's my pleasure. Thanks for the opportunity to present.
Thank you so much.
Thank you. Have a good rest of your day. It goes smoothly.
All right, thank
You
you.
as well.
Bye. Thank you.